Good morning or good afternoon. My name is Christoph Renner. I'm hemato-oncologist from Zürich, and I was asked to give my personal perception on this year's ASH. It is Monday morning in New Orleans, so I haven't seen all of the presentations or abstracts, so I might not be in a position to give a full comprehensive overview. It's a very personal overview, so I start in the area of lymphoma or multiple myeloma with what is the new trend or what is the new direction. I think the answer is easy. It's clearly immunotherapy, still some TKI, but mostly it's all about how can we activate the immune system either by checkpoint blockade inhibitors, by immunotoxins, by bispecific antibodies, or by cellular therapies such as CAR T cells. Now, if we go back to the question about is there still a role for chemotherapy or chemotherapy combinations in certain disease areas, I would say that two large randomized phase 3 clinical trials presented at this year ASH are really outstanding. One of them in advanced stage Hodgkin's disease is the HT21 trial. That trial is known to most doctors in Switzerland because we participated through the SAKK as part of that multinational large trial. As you might recall, BRCOP escalated either 4 to 6 cycles depending on PET2 is the gold standard for us. And the question was, can we replace some of the toxic drugs such as bleomycin with its lung toxicity by brentuximab vedotin, the 3030 immunotherapy compound, and the procarbazine as a very genotoxic drug by the less toxic dacarbazine, and reduce the long use of prednisone from 14 days to dexamethasone pulse therapy to 4 days. Now, Peter Borchmann didn't present the efficacy data. He was primarily focusing in on the toxicity data. And what he has shown is that the new treatment regimen called PreCAD was, as expected, much less toxic. You had lesser events of infections, you had lesser effects of neurotoxicity, you had lower rates of infertility, which was indirectly measured by FSH levels, either in women or in men. Now, he didn't comment on efficacy, but he was saying that the overall PFS and OS for both combined groups is excellent, PFS 94%. And he said that the rate of PET2 negativity in both arms is identical. So if we extrapolate from the PET2 negativity, we would expect that efficacy is pretty much equivalent. Now, because the escalated BRCOP is so efficacious, it will take a long time to look if there is a difference. There might even not be a difference between PreCAD and escalated BRCOP, but the summary is PreCAD is less toxic. So if we have now a younger patient with advanced stage Hodgkin lymphoma coming into our office, we should consider that regimen. The British, the Rattle, they were presenting their longer follow-up, and even they in the commentary had to admit that although better tolerated, and you know that in PET negative patients you can omit the bleomycin, the PFS data in a cross-study comparison are still lower than seen in the HD18 and now in the HT21, although it hasn't been split up between the two groups, as I said. The next one is the plenary paper number 1 presented by Martin Dreiling, which is the triangle trial, again a trial where the SAKK was participating. It's first-line mantle cell lymphoma. The Treatment of choice for the EU mantle cell consortium is the alternating R-CHOP R-DHAP for a total of 6 cycles, followed by high-dose chemotherapy. And then the debate was, is rituximab maintenance standard of care or not? And approximately halfway through the trial, most centers, or a significant number of centers, said because of the LYSA data, they would like to add now the rituximab maintenance. So roughly 50% of the patients received rituximab maintenance. Now, within that trial, the question was, does the addition of ibrutinib, either to induction or as a maintenance, improve outcome data? And can you omit the high-dose chemotherapy with autologous stem cell transplant? So the answer is yes, ibrutinib increases the response rate, and PFS is actually not even equivalent, but was superior in the ibrutinib arm without high-dose chemotherapy compared to the one with. And the ibrutinib maintenance was better than no maintenance with ibrutinib. Question is a little bit, what would have been the results if all patients would have received rituximab? Is R-CHOP, R-DHAP induction really a good or still standard of care induction regimen? So I think the data of Triangle are very encouraging. It's a little bit difficult for us to transfer that directly into clinical practice. I'm not sure if the health insurance will allow us to use it immediately, but it's certainly a good option to spare people the high dose plus autologous stem cell transplant, but then you have to put them on a longer maintenance treatment with ibrutinib. Tomorrow, on Tuesday, there will be an update of the ILS-G42 trial with CNS lymphoma, primary CNS lymphoma patients, and the results as given by the abstract would indicate that high-dose chemotherapy as a consolidation treatment is very effective in these young, fit primary CNS lymphoma patients. So I think these are the highlights for chemotherapy. Now it's getting a little bit more difficult if we move on to the immunotherapy field. There were so many abstracts on bispecific antibodies and in CAR T cells. In the aggressive lymphoma field, there were data showing that if you have achieved with glofitamab, which is a CD20, CD3 bispecific antibody in DLBCL patients, if you have achieved a CR for at least 6 months, then you have a very good chance of long-term remission, which is a little bit mimicking or equivalent to what we always claim for CAR T cells, where we say if you have a CR at least for 6, 9, 12 months after the procedure, you have a good chance of long-term remission. So it could be that we will have similar data for the bispecific antibodies as well. There were different bispecifics from different companies, CD20 or CD19 as the targets in B-cell lymphoma. Most of them, almost all of them, CD3 for the T-cell recruitment. We have seen data in indolent lymphoma, very good ones, in follicular lymphoma, in marginal zone lymphoma. No large randomized trials, mostly phase 1 or phase 2 clinical trials. So I think we will need more data, especially more randomized trials. But the direction is clear. You either add your bispecific to a combination with immunochemotherapy or to pure immunotherapy, or at advanced stage data, just the bispecific antibody by itself. My personal gut feeling here is bispecifics will move up to frontline combined with other immunomodulatory or modulating agents, and then at least in the indolent field, replace chemotherapy, and in the aggressive one, I think will be additive. CAR T cells, we saw updates for the Transform trial in second line, for the Zuma trial, and they just confirm what we have seen already previously. There are now subgroup analysis, which I don't want to go too much detail in, but at the end of the day, what we have seen at last year's age has now been confirmed with longer follow-up. In multiple myeloma, again, I would say immunotherapy is the clear winner regarding the number of presentation and abstracts to be seen and displayed. Similar to the lymphoma field, it is the bispecific in the CAR T cells. Again, we do have many bispecific constructs from different companies with different targets. It's nice to see that we are not restricted to BCMA, that we have other antigens now being recognized by bispecific antibodies, that we can even think about a kind of sequence. If one bispecific for BCMA, for instance, is not working, we can switch to another target antigen, but still keep the bispecific antibody format. The same is true, and pretty much the same targets are being explored for CAR T cells. Certainly the BCMA CAR T cells are the mainstay, but there are other targets recognized by CAR T cells as well. In CAR T cells, it's nice to see that people are thinking about how can we improve the production of our bispecifics. There are these so-called fast CAR T cell approaches. It's not only that this technology is used, but different academic groups, but mainly companies, big ones, startups, can now significantly reduce the production time for a CAR T cell product. So it's not much about how long will it take to produce a CAR T cell product. It's now more about the logistics, about collecting it, shipping it, and the production can be shortened to just a couple of days. I think this is very important for patients now waiting for a long period of time for a CAR T cell product. So it's good to see that these still on an individual basis produced products can hopefully be available much quicker. There are a lot of data on the genetics, genetic profiling, risk factors. The Iceland group with the huge registry data, the population-based registry data, have done a good job to come up with a kind of algorithm about the frequency of MGUS transformation to multiple myeloma. They have provided an app where one can calculate what kind of invasive, like bone marrow biopsy procedures should be done. And a lot of other groups have shown more insight into molecular subgroups in multiple myeloma. So this is my personal take home, mainly in the area of lymphoma and multiple myeloma. I hope I didn't miss any significant areas. And I think, again, it was an exciting, or it is still an exciting ASH. It's very nice to see how immunotherapy is really changing the field. And I hope that my summary was a little bit of help to those who couldn't attend, and looking forward to talk to colleagues back in Switzerland at one of the upcoming post-ASH meetings. Thank you very much.